Ahmed. I come from Canada, Toronto. Well, you're laughing, but he sent us a video. He couldn't join us because he had an accident lately. His back broke or something like that. But he's still active, very active. And he sent us a video with all the greetings about IOL fixation beyond the capsule. Those incredible gifted surgeons are the worst teachers because they put a video and they seem everything is simple, everything is easy, I can do it. This is the sign of a magnificent surgeon. When you see them, it's like a singer, effortless, he can produce incredible singing. Effortless, everything seems effortless. So, but Ike Ahmed has this incredible style of showing exactly what he's doing. And to tell you the truth, in order to be completely outside of this system, I haven't seen the video yet. So it's a premiere. It's a third time shown worldwide, and nobody has seen it before. So I hope it doesn't say any bad things about us. Let me start it. I hope it has a voice. It has a voice? No, they have it.
Significant innovations in ophthalmology and in medicine, of course, is designed to be placed within the capsular bag and nowadays modern cataract surgery capsule. These are my disclosures, and I send to you greetings from Toronto and from Canada.
I have to say that again.
Of course, we know the IOL has been one of the most significant innovations in view. My talk on IOL fixation beyond the capsule. These are my disclosures, and I send to you greetings from Toronto and from the modern cataract surgery. And I send to you greetings from. Hi, this is Ike Ahmed. I'm happy to share with you my talk on IOL fixation beyond the capsule.
Have you seen that? These are my disclosures. Now, the most important thing is don't show up without disclosures. In the old day, you said you're working with Alcon, you're a Bausch & Lomb man. Now, this is how great a guy is. That's why I was looking for it. He's a great surgeon.
These are my disclosures, and I send to you greetings from Toronto and from Canada. Of course, we know the IOL has been one of the most significant innovations in ophthalmology and in medicine. Of course, it's designed to be placed within the capsular bag and nowadays modern cataract surgery, but sometimes they're not able to use the capsule. So how do we tackle situations? How do we make decisions in terms of where to put a lens when there's no capsule? Well, no problem. We have many different approaches. Some of the context for where we may consider these situations are where we need to put a secondary lens in. The patient may require an IOL exchange, or we may consider doing a repositioning. The debate really starts with whether we should consider anterior fixation versus posterior fixation. Of course, on anterior fixation, we have the classical anterior chamber angle-supported intraocular lens, and we have the artisan lens, which is iris inclavated, which can be placed on the anterior iris or, for that matter, the posterior iris. Thinking about posterior fixation, we have various approaches that have been described more recently now. Intrascleral haptic fixation techniques, including the Yamani, scleral sutured approaches, and using suture material, and iris sutured options as well. One of the more common considerations in our practice is a lens that's in the capsular bag that requires repositioning. These may be 3-piece or single-piece lenses. We find regardless of IOL design, these can be refixated to the sclera using a sutured loop around the haptics. On the other hand, if the lens is outside the capsular bag, it may depend on what kind of lens is present. A 3-piece lens can be iris sutured, as of course the 10-degree vault on these lenses often help, or can be intrascleral haptic fixated, repositioned to the sclera with those haptics. However, a single-piece lens is not really amenable for iris suture fixation or for intrascleral haptic fixation. One, however, could use an IOL piercing technique or a punch through the optic material or haptic material. Both iris suture repositioning or scleral suture repositioning are both options for patients who have dislocated lenses. Now, considering scleral fixated lenses, one of the considerations with this approach is that these patients typically require a more extensive vitrectomy, certainly an adequate vitrectomy, and in my experience, we like to use typically a pars plana approach and infusion line, although some do use an anterior chamber infusion line and do a limited anterior vitrectomy. This is a critical part in managing these lenses as we're manipulating the lens and haptics in the anterior vitreous space, and it's important to ensure that an adequate vitrectomy is done. And for this reason, for some cataract surgeons, this has been a little bit of a hesitancy. Understandably, amongst vitreoretinal surgeons, this is a very common approach. One of the benefits of this approach is that there's minimal uveal contact with the lens, and IOL denesis and movement is less likely. However, it's important that external landmarks are respected and critical to position the lens to ensure it's not anteriorly or posteriorly positioned in the eye, which could cause UGA syndrome or optic capture or bleeding. Scleral fixated approaches are prone more to IOL tilting and decentration, and it does require, of course, conjunctival scleral manipulation and often externalized elements which may pose a theoretical risk for infection or erosion. For scleral fixated approaches, any lens of any design in the bag can be used to reposition. When there's no capsular bag, a three-piece lens can be used, or an IOL with specially designed eyelets can be used for scleral fixation. And of course, in the absence of capsule, this is the most physiological position for the IOL. However, as mentioned earlier, one of the problems with scleral fixated lenses that we've seen with various studies and imaging is the lenses may be placed too anteriorly, fixated to the sclera too anteriorly, causing irritation and rubbing onto the iris with bleeding, optic capture, uveitis, and glaucoma. And so one of the most important considerations is to consider where should these lenses be fixated. And because we're using external landmarks, it's important to consider this. Most surgeons use the limbus as a guide to where the lenses should be positioned. For example, placing the lens 2 millimeters back from the limbus. The problem with that approach is that the limbus to lens distance can be quite variable depending on the axial length of the eye and the refraction of the eye. So instead, we prefer to use the posterior edge of the blue zone, which is shown in this picture, as opposed to the visual limbus. The posterior edge of the blue zone, of course, is where the sclera essentially starts and where the angle stops, and externally. If we drew a line straight down, vertically and perpendicular to the scleral plane, this would position that place at the anterior trabecular meshwork. Now, for a glaucoma surgeon, this is an important area to consider. We often place our tubes in this position. We're not interested in that in this situation here. However, if we go back 1.5 millimeters from the posterior blue zone, that invariably positions us quite reasonably well to that zonular plane. And that distance from the posterior edge of the blue zone to the zonular plane is more consistent than just using the limbus. That's typically what we use here. Here's an example. In an average eye, we see the limbus, we see the posterior border of the blue zone, and we see where that zonular plane would be 1.5 millimeters back from the posterior border of the blue zone. Now, in many eyes, that posterior border of the blue zone is a set distance from the limbus, but in smaller eyes, it may be closer, and in longer eyes, it may be farther. On average, again, it's a millimeter. But by using the posterior blue zone, this avoids some of the issues we have with this variability. And by going 1.5 millimeters back from there, this helps us. If we were to use a limbus, based on, again, on this diagram, we should be at least 2.5 millimeters back from the limbus when we're fixating elements if we're not using the posterior border of the blue zone. This video demonstrates an example of an IOL in the capsular bag. It's a one-piece lens that has sublux due to exfoliation, and one of the things we like to do is basically place iris hooks to support the capsular rhexis so the IOL is positioned for us and not moving around during fixation. Here we used a radial incision. Here, centering the needle passes 1.5 millimeters back from the posterior blue zone. So that means about 0.5 millimeters above and below that zonular plane. This allows there to be a gap between the needle passes, pasting this around the fundus of the haptic through the posterior capsule and anterior capsule. And there's no knot on this, so there's a risk, of course, for the suture to slip. But by placing it through fibrotic capsule and being very careful to avoid excessive tension while tying the suture, this avoids the suture loop from slipping. And it's that suture tension that is very important when it comes to adequate centration and minimizing tilt and minimizing the sutures from slipping off the haptic. There's some debate what suture material is ideal for this. We like using the Gore-Tex material, CV8, which is equivalent to a 7.0 Gore-Tex suture. Proline can be used as well, and 9.0 proline can be used in this manner as well. And there are other approaches that we'll discuss using other suture material like 6.0 proline. This is a more extreme example of an IOL that's placed in the capsular bag many years ago, and it's completely subluxed. There's also a capsular tension ring here inside the capsular bag, and you can see the lens is sitting on the retina. After doing a full vitrectomy, ensuring that we've removed vitreous and any traction, shaving the vitreous base, we now can bring the lens forward here using the vitreous cutter on aspiration. And you'll see when we bring it forward, it actually is a multifocal lens. The patient actually was very happy with the multifocal lens and has a multifocal lens functioning very well in their fellow eye. And so it would be optimal to try to refixate this lens to the sclera. Again, we will use the iris hooks, which we've mentioned earlier, which are very handy to use. Even years later, we can grab the capsular rhexis on the capsular rhexis edge here on top of the lens material with one hand and place an iris hook to secure the capsular rhexis edge. This allows us for the lens to be fixated into position here to ensure that we have it positioned to allow us to pass the sutures and have free hands. We now can pass our sutures. We're going to make sure that we're 180 degrees apart from each other. If it's a toric lens, we're going to position this lens along the axis of the steep axis of the eye. And you can see we basically placed a mark at the posterior edge of the blue zone. We'll place our radial incision. And we're going to place our passes here above and below that 1.5 millimeter plane behind the posterior edge of the blue zone. Here we're placing the needle pass right at the haptic-optic junction. Again, as I mentioned before, these suture passes are made above and below that zonular plane we're trying to attempt. So basically, if we're looking at the posterior blue zone, this would be 2 millimeters back from there and 1 millimeter back from the posterior edge of the blue zone, centering there 1.5 back from the blue zone. Sorry if that was too complicated, but hopefully you can think about it and draw it out. Second pass is made above the entire capsular bag. The first pass was, of course, through the posterior capsule and anterior capsule. We'll pass it through. Typically, I like to do a slip knot temporarily, and then we can secure it after the second pass is made. There we're visualizing the haptic-optic junction. This particular lens has a little notch on it, which is nice. We're using a 25 gauge needle with that Gore-Tex to dock it. Again, going behind the posterior capsule and anterior capsule, passing it right through. And again, this is the posterior pass. 1 millimeter anterior to that, we're making the anterior pass. And therefore, the sutures are again centered 1.5 back from the posterior edge of the blue zone. And now we can do a slip knot. We will carefully look at centration here. This is particularly important, of course, for this lens. And we can then secure this and tighten it just with enough tension. Just make sure it's snug enough so it's not loose or decentered, but not where it's tilting or slipping off the haptic. Again, we put some myocall in to bring the pupil down, look for centration. We're happy with it. We can lock the knot. And very important to bury those sutures in the sclera through the sclerotomy that's made with those 25 gauge needles is what's important to ensure that we do that adequately as well. And looking at the postoperative ultrasound biomicroscopy, you can see the operated eye IOL is almost as good and maybe even reasonably positioned compared to the unoperated eye quite nicely. Now, of course, we're in the era of the intrascleral haptic fixation technique, or the Yamane technique, using the haptics of a lens to place it within the sclera. It does help us to have an adequate lens of strong haptic material. The Zeiss CT Lucia is our preferred lens. The Sensar is a second option as well that may be more widely available. We need a 30 gauge thin-walled needle. This will be ideal. 30 gauge is ideal to capture that, as Yamane described. but it should be thin-walled. And if not, then a 27-gauge needle can be used, but this makes a larger scleral tunnel. A low-temp cautery is also used to melt the tip.
So
This
he sees,
particular patient
they
has
gave
a
you
subluxed
the
IOL with
directions,
Somme rings in the
what
caps
is
of the bag.
necessary for your money.
We've decided to remove this lens and explant it here from the eye after cutting it in half. And then we will continue here to perform an adequate and full vitrectomy. This patient had a previous vitrectomy. We'll do some more. Again, visualizing the peripheral retina, ensuring that we release any traction, shaving the vitreous base, clearing all the vitreous, and examine the periphery. Now, 180 degrees apart, we're marking the eye here. I like to use a Sinskey hook marked with ink to have more controlled dots. 2.5 back from the limbus is what we're using in this example. Although we can use the blue zone, it's harder to evaluate that when we're not opening the conjunctiva. So I do use a limbus 2.5, but not 2 millimeters. This is 2 millimeters scleral tract, making it adjacent to those dots. So 2.5 back from the limbus and 2 millimeters across is what we do. This is a C2 Lucia lens implant placed here into the anterior chamber first. It provides a temporary location for this lens. And then we'll use a micro-tire instrument here. Now, one thing I'm going to show you here is we're using a little iris hook sleeve. This has been described before here to secure the haptic temporarily, but I'm not using it for that purpose. I'm using it to actually measure 2 millimeters from the needle tip. This is one of the most hardest things to do, is figure out how far is 2 millimeters, because you can't see the needle as it goes through the sclera. Angling down here at a low angle here, once we reach this cuff here, we turn into the eye, and that's 2 millimeters. That length is so important to ensure we don't get decentration of the lens on both sides. Micro-tire is used to grab the haptic, nicely place and dock it within that needle. We usually do 3 pushes into that needle hub there as well. And then we'll leave the needle and the haptic in position on this side and remove the syringe from the needle hub. Again, we have this sleeve, which is from the iris hook. We've taken it out and pierced it through the needle to mark 2 millimeters. It gives us a guide. Once we're in there, we can then turn into the eye. And this assures us of 2 millimeter distance. As I said before, that's one of the challenges, to ensure we're adequately distanced from the limbus, 100 degrees apart, and also 2 millimeter scleral tunnel. Those are the 3 important aspects of Umani fixation. This trailing haptic sometimes is harder. We're going to use the back wall to guide the haptic along the back wall of the bevel of the needle, to guide it in and push it forward. And then we'll rotate the needle and come out the same way we came in. This is the trailing haptic. We're going to come out and actually melt the trailing haptic first, grabbing the haptic with the curved tire, pulling it out. Be careful not to flick or cause any bending or twisting of the haptic. We're melting the haptic, but don't bury it yet. Pull it out here, and we'll see why. We're going to pull out the leading haptic here. We'll grab it. We'll melt it again here under dry circumstances. And before we actually bury it, we're going to make sure we're same distance from the scleral pass, so the haptics are equidistant from the sclera. And now we can check for centration. This allows us to make any adjustments before we bury the actual haptics. And if we're happy with the centration, we can then bury it. If we're not happy with it, we may cut one side to recenter or even redock again. Once we bury it, it's harder to do that. So we can bury it there, nicely positioned as we can see here. And this is the approach I like to do to get good security. Make sure those haptics are buried in that sclera. We can see it, so to prevent any erosion. And the lens is really beautifully centered in this position here. It's a very nice, elegant technique. Complete the case here, doing a fluid air exchange and closing the case here. Now, there are specially designed lenses, like the Carlavali lens, which is designed specifically for scleral fixation, which is a very nice approach as well, that can be used in a foldable design. And there are also foldable lenses that can be used that are not designed for scleral fixation, but that can be used with sutures. In this case, an example of the MX60 toric lens, which is very nice to use for high astigmatism, where you can see we place sutures through the haptic optic junction, those eyelets here, and pass the sutures here at the same positions we showed earlier on either side. I typically will cut the haptic here off the optic here, and then we'll place the lens into the eye. Again, very important to adequately tie the suture with the right tension And this is the toric lens, and so it's a great way to correct high degree of toricity in an aphakic eye. We're just going to, again, lock the sutures, or slip knot the sutures, and then lock them once we're happy with them. The passes, again, are made to center of the lens 1.5 back from the posterior blue zone. The needle passes are 1 millimeter apart from each other in a radial incision, as we showed here again, and bear those knots, and we have a very nicely positioned lens here in this toric patient. Here's the example of the UBM. Now, a couple of Brazilians have described some nice approaches here using an IOL piercing approach. Derval Carvalho has described this using a very nice punch through the haptic or through the optic, and also using Canabrava's approach, using a 6-proline suture can be used as well to fixate these lenses. Now, moving to iris fixated lenses, of course, in this approach here, we are suspending the IOL haptic from the iris. This is the fixed distance from the iris. And in this manner, because the haptics are vaulted and the optic is posterior vaulted, the optic remains posterior to the iris in a fixed manner. In fact, we usually find that the risk of Ike syndrome is actually even less because the lens is fixed from the actual haptic itself. And if we do this right, we can avoid pupil ovalization. So the benefit of this approach is that there's no external haptics or sutures, no needle passes or contact manipulation. One benefit from an anterior perspective is that there's less vitrectomy required, and we get excellent centration on the pupil with less tilt. This can be very helpful for 3-piece lenses that are out of the bag, but we don't use this for 1-piece lenses. It does require us to have a stable iris, and there is a risk of IOL denesis if the iris is quite mobile. Peak pupils can happen with inadequate technique. And of course, we worry about uveitis, of course, in these situations, which is certainly a concern. But because the lens is suspended at those 2 points from the haptic iris fixation, the risk of having chafing of the iris is minimized. However, not, of course, completely eliminated. There are various ways to suture and tie the iris suture, which we recommend a variety of different approaches to learn. And here's an example. We have a 3-piece lens that was placed in the sulcus but has subluxed due to adequate support. Sorry, this lens actually is in the capsular bag, I should mention here, 3-piece lens. But we certainly do this approach as well when the lenses are subluxed in the sulcus. We're bringing the lens in the anterior chamber. We cut the lens out and remove the entire capsular bag. And although we could have refixated that lens, we're putting a new 3-piece lens in here. And we're showing here the approach. First, put it in the anterior chamber so it doesn't fall back in the vitreous. We can then do some anterior vitrectomy to ensure that the retropupillary space is cleared, although we don't need to do as much of a vitrectomy as we do for the scleral approaches. There's less manipulation in that space. We'll now grab a microforceps on the optic, placing the haptic behind the iris on either side while holding the optic. A hook is used to place the haptic behind. And then we'll bring the optic forward to ensure that we have it now captured in the pupil. Some myostat is used to bring down the iris, bring down the pupil, and now we're using a CIF4 needle. This is the curved 10-proline needle on a curved, gently curved needle. Mid-peripheral iris, grabbing a small body of the iris alongside the haptic through the anterior and posterior iris. Lifting up on the optic helps us and go mid-periphery to avoid ovalization, although we don't have to go too far into the angle. And then come out, make sure that we have these incisions adequately placed. We then can tie the suture using a variety of approaches. Here we're going to use the McAhmed approach. And this is using a micro tire in the eye, 2 micro tires in the eye to tie the suture. This is a nice controlled approach. It does require us, of course, to use closed system approaches and techniques. We'll grab the suture and then tie it into position. Now, don't tie it too tight yet, and don't lock it certainly, because we'll show you what I like to do that before to ensure we don't get pupil ovalization. So there we go. We have a nice knot around it. For the trailing haptic, we're going to use a modified Siepser approach where we pull both sutures ends out of the eye, and we tie outside the eye, and then we push it in. This is actually a modified mechanical or so-called McAhmed approach, I should mention, although a Siepser approach can be used as well. Tie outside the eye and then push it into the eye using a micro tire. This is an even easier approach to learn and allows us to control the suture pass here as we pass it into the eye. Now, before we lock the suture, we're going to dunk the optic behind the pupil, and you'll see the pupil is ovalized, and not surprising because the iris is bunched up, is caught in the knot, which is not surprising. So simply just pull on the iris and pull on the suture, release the iris that's caught into the knot, and then we can be sure that the iris is free and the pupil is nice and round. We do this on either side to ensure of that roundness there. And then we can cinch the knot, pull it tighter, and then we're going to lock it in place. Lock it using, of course, a reverse throw to grab the free end and lock it in place. Typically we do a 3-1-1. And then we will cut the suture here on either side, and we have a very nicely positioned three-piece lens to the iris. Now, iris sutured IOLs have not been as commonplace for a variety of reasons. It does require some technical approaches, but we've been very pleased with this approach overall, and it's a good option compared to scleral fixation. Of course, anterior chamber lenses we mentioned earlier are an option, the Kelman multiflex, angle supported, or the Artisan iris head-clevated. Technically less involved. They certainly less need vitrectomy. Sizing can be a problem, however, for angle supported lenses. And of course, these lenses sit closer to the cornea. And there's some concern, of course, for angle issues and for certainly endothelial concerns, and this does require a larger incision. These are typically PMMA lenses. The other option, of course, is to do a retropupillary implantation of the iris claw lens. Now, just to, before we finish off, talking to summarize here, what is the impact of these fixation IOL positions on post-op refractions? Of course, this really is going to depend on what is the effective lens position. We have all these formulas to predict where the lens is going to sit. This is based on in-the-bag placement. But what about alternate fixations? Well, here's some examples of in-the-bag position on the top left, the UBM showing the elbow in the bag. The sulcus position of a lens, if it's placed in the sulcus, is of course anterior to that position. The ELP is anterior, and the refraction, of course, will be more myopic if we don't adjust the power. Optic capture can be looked at, reverse optic capture, and posterior optic buttonhole are all other approaches of capsular fixation. We didn't discuss these approaches, but they each will have their unique position of the lens compared to the capsular bag. This is again in the bag, and this is iris sutured. You can see the lens sits more anteriorly. Scleral fixated and intracapsular fixation, you can see, sit closer to the in the bag placement, although with our approach, they may sit slightly posterior. Here's the effective lens position. This is in the bag placement you can see here. And what you'll see is basically sulcus and iris fixated lenses sit more anteriorly, as I mentioned. Optic capture, reverse optic capture is somewhat similar, although sits actually a little bit farther back from in the bag. And our scleral fixated positions of our lenses sit farther back. This is again using the landmarks we mentioned, and we use those landmarks as important to ensure that we avoid iris contact. Now, typically in an average eye, 1 millimeter error of effective lens position results in about a 1.5 diopter of refractive error. This is the mean arithmetic error. You can see that if we calculate this from the bag, we get a myopic surprise for iris fixated lenses and sulcus fixated lenses. So we need to make an adjustment. However, for scleral fixated lenses, we typically don't need to make much adjustment, although there is some variability with those placements. So here's our adjustments. Optic capture, reverse optic capture, scleral fixated, and sulcus or iris fixated. We know the ELP is anterior for these sulcus and iris fixated, a little bit posterior for scleral fixated, and similar for optic captures. So we typically reduce the IOL power for iris fixated lenses, but it's pretty similar for scleral fixated lenses, assuming we use the proper landmarks. There's more variability, of course, with iris fixated lenses and scleral fixated lenses as well. Now finally, the final question is, what is the best IOL fixation approach for your patient? Well, we don't know if there's any clear differences, to be honest. The ophthalmic technology assessment from the American Academy report, here published recently, really didn't show any evidence for superiority for any single IOL approach with similar visual acuities and similar risks. Of course, it's very difficult to study these. This chart summarizes our approach here based on angle-supported IOLs, artisan lenses, iris sutured lenses, sclerosuture lenses, and haptic fixation. Of course, the anterior approaches, we worry about the cornea and angle. We need the iris for iris sutured lenses or for IOLs in the anterior chamber. For suture fixation, there's some suture breakage issues. For external haptic fixation or scleral fixation, there's a risk of infection and more risk of tilt. There's more denesis when lenses are placed on the iris, and pupil ovalization for anterior chamber lenses. And particularly important for the scleral-fixated lenses is the need to do an adequate vitrectomy. This is important, and if we're not comfortable doing a good vitrectomy, then scleral-fixated lenses are more problematic. This is where iris suture lenses, of course, or artisan or ACIOLs have an advantage. And technically, of course, there's some differences. So really, it's going to depend on the clinician and the eye in terms of what the right approaches are. In our book, we published a variety of approaches that can be looked at to describe these techniques in more detail. And I always want to finally thank my fellows and all my visitors and observers that have come and visited me over the years. I've learned so much from them, and we've gone through these cases a lot. And I invite all of you to visit Toronto one day and come and learn together and enjoy our time together. In the meantime, of course, keep in touch online and keep the movement. Thank you very much.
Well, we can go home now. Nothing more to see. That's what I call a master. Looks everything simple, explaining everything, telling you step by step what you should do, giving you the right directions, and now we will try to have a miracle. A miracle. Ike is waiting for our phone call in order to answer a question. Who speaks the Canadian language? In Japan, I think welcome home. In Japan, you think you speak Canadian? No, no, no. In France, Yannick, no Canadian. So we will try to connect with him and he can give us some answers. And the other thing I promise you, and I'm going to deliver, is this video is going to be sent to your emails or to your WeTransfer to everybody. So don't make any notes, don't take any pictures, just send the money. Oh, okay, we sell it, it's not for free. If it's free. If it's free, you don't appreciate that. I found out from my patient. If I tell I don't want any money, they say you're not good. So overall, until we get any questions on the procedures, on what you expect, what you have, what would you like to do, because sooner or later, about 8 o'clock, I'll tell you to finish the program. After the discussion with Ike, if you can, then we have the famous Yannick Lemaire, professor, to give us his lecture. And then we have Igor, who is coming all the way from Germany. Am I right or not? Germany?
Barcelona.
Barcelona, what is this place? Barcelona. Venezuela, okay. And he's going to tell us a show about the simulator. So he's going to tell us what are the possibilities, how you can use it. So tomorrow, whoever wants to use the simulator would know the steps. In order to make a phone call, we use Irini because he can give also a picture of who's calling.
Can you hear us?
Yes. Hi there.
We can hear you as well.
Hello, my friends. It's Ahmed from Toronto.
Hello, everybody. Ike, this is Thanasis. Everybody speaks Canadian here. We understood completely. You solved all our questions. So you're not used anymore. So you don't have to come anymore. You just send us the video. Everybody was taking pictures there. I don't know if you can see us. Can you have a...
You can come here. So
Okay, I
from the
will come and take a camera.
Well, I hope to visit you in the future, my friend. To your amazing program and.
Well, I made a lot of mistakes trying to imitate you. So you solved a lot of the questions that everybody had. All day we had a discussion here, and you solved a lot of questions. So just let me turn around if I can and show you so many interesting people. They even come to South Africa. They like to very much to South.
Hey, everybody. Wow. What a nice crowd. Really. That's amazing. Well, you're a great educator, my friend, and you love to share. I mean, that's what I like about you. You share, you give yourself, and you are all about helping everybody else. So I love that.
Because I need the money. And in Canada, you have another system, so you don't need that. It's just the social system. So you make difficult things look simple. We'd like to, there is Yannick Lemaire from France, there is Ferrara from Italy, there is the Japanese name, say that again? Kusaka, the professor from Japan.
Amazing.
Also today, there's a famous Hanning from Brazil. He is going to come to your place. No way to escape him. He's huge, and we would like to ask them if you have any questions. And Professor Mavroudis, who organized it, he's a cataract guy, refractive guy, and we had a lot of cataract and refractive guys here that would like to learn how to treat cataract complication by anterior segment MAD. We got 15 stations, and if you not in a hurry, we'll take the laptop and take you to the wet lab to see what we want you for next year if we survive the traffic. We have a lot of airplane problems.
Yes.
People were coming without the luggages were coming without people, and we tried to fit in. So we're sharing the luggages now. It's something.
I'm sure, but I mean, but the blessing is having everybody there and doing it together.
It's not everybody. A couple of them are going to come tomorrow. A couple of them are going. They have visa problems. It's a funny thing when you make a lot of people come at the same time. They try they envy us. They don't like to succeed. So they put obstacles like airport companies or coronavirus. But really, anybody who'd like to have a talk with, even say thank you? Well, everybody say thank you. So I'm going to give the laptop. I'm going to take you inside the wet lab and let Yannick Lemaire take the pendulum. Can you please move this? Or I need to have the voice on. Can we move this to shorten?
To remove it. Okay. So you're going to be.
Yes, I'm going to be traveling around. Yes.
Okay.